This seminar or webinar, as we call it, is being sponsored by Intas pharmaceutical firm, Ultima Division. One of their famous product is Rejunex CD3, then Levera. Hello, yeah. And I welcome all the speakers. We have come here well in time today. I'm very happy. Dr. Oscar Alves from Portugal, Dr. Jay Sardara from HEPJ Lucknow, Dr. Rohidas from Kolhapur, and Dr. Varnan Vello, he's from JJ Hospital, Professor in Mumbai. I, of course, is in Lilavati Hospital here in Mumbai. I welcome all the viewers who have already joined this webinar in very large numbers. And it is such a pleasure for me to see that enthusiastic viewers who are joining our webinar in spite of the fact there are as many as half a dozen webinars going on all over the place. With this few words of introduction, I now request Dr. Varnan Vello to give his presentation on pathophysiology of cervical disc, because today's topic is the management of cervical disc prolapse. I may remind you that at this time that I was the one way back, many years back, who propagated and very strongly advertised anterior approach to the cervical spine way back. And when I put my video on the YouTube, it was viewed by more than 100,000 viewers. So I knew there was a need for the people to learn about anterior cervical approach. Then what followed is the evolution, the progress, and then we have gone further. Most important is that why these prolapses in the cervical spine. Dr. Varnan Vello, please.
Thank you, sir, for a wonderful introduction. I shall now share my screen.
So click on the presentation.
Sorry?
Please click on the presentation and then you can go on the beginning first slide. Yeah, now you can change with the arrow keys. Yeah.
Okay, thank you. I'd like to start my presentation, Pathophysiology of the Cervical Disc Prolapse. This is my hospital where I work. And just to show you some very strong cervical spines, like this is the cervical spine of the bull. And that's why we have only bull fights and no other fights. And then we have the elegant and strong cervical spine of the giraffe, which is one of the strongest spine in nature. And just to show you some common features. Now, this is the cervical spine of a human being. This is the cervical spine of the bull, and this is the cervical spine of the giraffe. The common feature is that all these have 7 cervical vertebrae, but the weakest of them is the human cervical spine because of the way the joints are aligned. And if you see here, the joints are more, they are more prone to damage as compared to that of the bull and that of the giraffe. And these joints are basically almost like ball and socket joints. So now we have evolved from the ape, and if we see the monkeys and apes, they would use their hands to walk and hands to climb, and that would also decrease the amount of force on the cervical spine, and the cervical spine muscles also were well developed. And as we evolved and had this standing posture, the damage and the pressure on the cervical spine increased, and today we have gone into a posture like this, which is causing the major problems in the cervical and the lumbar spine. So just to come about the anatomy of the cervical vertebra, it's identified by the presence of the foramen transversarium. There are 7 cervical vertebrae, which are 3 to 6. They are typical ones. The first, second, and 7 are atypical. Now, 6 intervertebral discs do exist, and there are 8 pairs of exiting nerve roots. So what's the typical cervical vertebra? It is made up of the body, the vertebral foramen, and it is also made up of the arch. And if you see and compare these vertebrae, they are almost completely delicate vertebrae as compared to the dorsal or the lumbar vertebra, which are more heavy and which are more designed to bear a lot of stress. So if you see here, this is the cup where the disc fits. This is the foramen, and you have the anterior and the posterior tubercle, and also the conchotransverse ridge. And if you see the spinal canal, it is triangular, while the cervical cord is oval. So there is more chances of the cord getting damaged in this area. So one has to know the anatomy of the transverse process of this typical cervical vertebra, which has the anterior and the posterior tubercle and the costotransverse bar, which is also important as it forms a strut for the attachment of the muscles. And the anterior tubercle of the 6th cervical vertebra is the largest, and it is also known as the carotid tubercle. So one cannot forget the anterior and the posterior muscles, which are the first line of defense for the cervical spine to bear the brunt. It's the muscles which bear the brunt. So the better the muscular strength of the cervical spine, lesser the chances of the injury to the cervical spine. So coming to the anatomy of the normal disc, this is an avascular fibrocollagenous material. It is composed of 3 components: the inner nucleus pulposus, the outer annulus fibrosus, and the end plates. The nucleus pulposus is made up of type 2 collagen, and the annulus fibrosus is made up of type 1 collagen with 12 concentric layers of lamella with alternate layers of collagen. So it's a beautifully layered structure, and this is what makes this disc unique. What are the contents of the disc? It is water, proteoglycan, and collagen. And the collagen types are 1, 2, 3, 5, 6, 9, and 11. So the nucleus is basically water, proteoglycan, and type 2 collagen, and the annulus is type 1 and type 2 collagen. So what are the basic functions of the disc? It acts as a shock absorber. It allows compressive, tensile, and rotational motion, and it forms part of motion segment along with the ligaments. So the ranges of motion are different in flexion, extension, lateral bending, axial rotation, and that's why the cervical spine has the maximum ranges of motion. And just to show you the weight-bearing axes which occur in a normal lordotic spine, and how the weight-bearing axis changes in a kyphotic spine, which starts in the degeneration phase. Now on this side, you'll have the common sites of vertebral motion unit sprain, which is the disc, the end plate, and the ligaments in the spinous process, and the capsular ligaments. So what is the etiology of disc herniation? When part or all of nucleus pulposus herniates through annulus fibrosis, and there are 2 types, acute and chronic. Acute, although rare, it does occur. It is mostly seen in traumatic conditions where there is a defect in the annulus fibrosis and there is a sudden onset pathology and more severe symptoms. Chronic, in chronic, you see the disc becoming degenerated and desiccated. There's a natural aging process and a gradual onset which takes place, and the symptoms are less severe as compared to acute, but definitely progressive. Mostly the age group is between 50 to 60 years, but in traumatic conditions, it is the younger age group. Males are more prone to this prolapse than females, and the predisposing factors are frequent heavyweight lifting, trauma, and the most common area is 5-6 and the C6, C7 level. Now, cervical disc prolapse, it is also associated with motion abnormality and loss of disc height. There is arthrosis in the uncovertebral and the facet joints, leading to spur formation and compression of cord nerve roots from the front, and facetal arthrosis and ligament redundancy, causing compression of the spinal cord from behind. So age-related changes in hydrophilic proteoglycan leads to reduction of water and content of the disc, and desiccation of this disc material and loss of disc height occurs, there's a greater stress on the articular cartilage, vertebral end plates, and joints. There's a loss of normal cervical lordosis and the formation of osteophytes. This in turn gives rise to a narrowing of the neural foramina and spinal canal. So the types of cervical disc prolapse could be central, posterior lateral, foraminal, and extraforaminal. And also we can have the different types of weakening of the annulus fibrosis, which further results in the tear of the annulus, a complete sequestration of the disc, and sometimes migration of the disc. So these are the different types of disc prolapse. This is normal, this is a degenerated disc, a bulging disc, a herniated disc, and of course, a degenerated disc with an osteophyte formation, which we would label as the hard disc. So the stages basically starts with degeneration, it goes to prolapse, it goes to extrusion, and then to sequestration, which in turn gives rise to a dynamic cervical spinal stenosis. So we also have the ODOMS classification, which could be a type 1, a unilateral soft disc protrusion with compression, type 2, foraminal spurs and hard disc, type 3, medial soft disc protrusion, and type 4, transverse ridge or a cervical spondylosis with spinal cord compression. So coming to the inflammatory response, any disc prolapse produces a combination of mechanical compression of the nerve by bulging nucleus pulposus and a local inflammatory cytokine release. And this is the interleukin-1/6 substance P, bradykinin, alpha prostaglandins, which play a role in this inflammatory process. And of course, the compression can later lead on to venous and arterial ischemia. So just to show you this video, which I got from the YouTube. Now, this is the flexion and extension, which normally takes place, and even the lateral bending, which can take place. And this is the disc, the surrounding annulus. And once it gets compressed, there is a gradual change which occurs in the nucleus pulposus as well as the annulus fibrosis. There's a thinning out of the lamellae of the annulus fibrosis. And as this thinning takes place, the water content of the nucleus pulposus also decreases, which in turn produces this bulge. And this bulge, mostly seen in the posterior lateral area, compresses the nerve root, or it can compress the cord if it goes in the central area. And later on, there is a rupture of the annulus fibrosis, which causes herniation of the disc and inflammatory changes around the nerve root. So the trajectory of the cervical nerve while exiting neural foramen makes it susceptible to stretch in addition to compression by herniation. And the disc prolapse is usually in the posterior lateral direction because the strong posterior longitudinal ligament prevents direct posterior herniation. So coming to clinical presentation, it is mainly neck pain, cervical radiculopathy, cervical myelopathy, and 75% of these patients, they go on to a stepwise progress and deterioration. So a herniated disc normally impinges upon the nerve root exiting above the disc and passing through the nearby foramen, resulting in involvement of one specific neurological level. So cervical radiculopathy is basically pain and paresthesia along the cervical nerve root distribution and motor deficits involving the nerve roots. I'll skip this video. So coming to special tests, one is the Sperling's maneuver, which is a gentle compression test. We have the Lehermertz sign, which can be elicited, the Mizuno's test, and the distraction test, where one can gently distract the cervical spine by holding the occiput in the mandible, and the pain reduces. The compression test produces pain. And these are the classical nerve roots and the muscle groups which are involved, depending upon the disc which is involved. So cervical myelopathy, one can have spasticity, weakness of upper and lower limbs, gait disturbance, sphincter disturbances, and difficulty in performing fine finger movements. So based on the amount of disc prolapse, the site of the disc prolapse, and also the amount of cervical stenosis which is involved, myelopathy will get either from the sides, from anteriorly, or from posteriorly. So basically, one can evaluate this degree of myelopathy with the Neurick's grading, which you see here, which starts from 0 to 5. And coming to investigations, X-ray is the good modality. And now we have CT, MRI, the EMG, and also the dynamic CT and MRIs, which definitely help us to also find out subtle disc prolapses. Of course, the X-ray will show you the reduction of the disc heights, especially, and the changes in the end plates when there is a disc prolapse. The myelogram, although it is not used now, was a beautiful investigation, which you can see a beautiful prolapse of this cervical disc. However, it is invasive and not used now much. Coming to management, first it is the conservative management, which involves NSAIDs, opioids, muscle relaxants, antidepressants, and certain anticonvulsants which have a role to play in neuralgia, and cervical epidural steroid injections. And the non-pharmacological therapies would be cervical collar, cervical traction, physical therapy, which could be thermotherapy, ultrasound, TENS. However, chiropractic is mentioned, but it should not be used in my opinion. And of course, the surgical approaches come into play when the conservative management fails, and the surgeries can be ventral or dorsal, which my co-speakers are going to elaborate now. And the factors that predict this poor neurological recovery is if the transverse area at the level of maximal compression is less than 30 square millimeters, if the age is advanced, if there is preoperative neurological status which is not good, if the number of levels involved are more, if the degree of residual compression after surgery is still there, and if myelomalacia is significant at the time of presentation. So if we have a spinal cord which is looking like this, then the chances of recovery are less as compared to this. So thank you for your attention. Hello. Huh?
Hello, yeah.
Yes.
Can you hear me now? Yeah.
Yes,
Dr. Vardhan, thank you very much for your very illustrative, very lucid lecture. It was well understood by everybody and well appreciated, I think, by everyone. There may be some questions to ask you, but we will keep that at the discussion. Now, with that, I will hand over the mic to Dr. Sumit Pawar to further proceed with the webinar. Dr. Sumit Pawar.
Thank you so much, sir. Dr. Varnan has taken us with the journey of the cervical disc, how it was intended to be made, and what we have done with it, the process of degeneration, and the way to go forward. I am very sure it was well understood by everyone. And now, what is better for us to learn is how to approach the disc from the what Dr. Varnan has said, the anterior approach, posterior approach, the newer techniques of the artificial disc and endoscopic approaches. The workhorse of cervical disc herniation is the anterior approaches. And who better to teach this than the master who has devised, popularized, and taught almost everyone in India this technique, Dr. Ramani. I request Dr. Ramani to please start the presentation on anterior cervical disc herniation and its management with the anterior approach. To you, sir.
Thank you. Thank you very much, Dr. Sumit Pawar, for that very nice presentation. As you know, I'm old, but I still work actively in this Lilavati hospital in Mumbai. I'm a microsurgeon. Just now, Dr. Vardhan Value showed us very good illustrations of the cervical spine and which causes disc. On the left side is the normal cervical spine. The disc is very common in this patient who are very young, either because of trauma or sudden jerk or something. Then in the middle, of course, you have got the degenerated spine. As Dr. Varnan told you, osteophytes anteriorly and posteriorly. The one in the posterior compressing on the root and then giving rise to the symptoms along with the disc prolapse. Then up to right is the extreme condition of OPLL, which can cause symptoms both cervical radiculopathy and myelopathy. You will be surprised to know that one of the most actively moving spine portion is cervical. At its disc height is very small, only 20% in comparison lumbar, which is 30%. What is the purpose of ACDF? We have to decompress the spinal cord and the nerve roots, of course. Restoration of the segmental height, if it is reduced. Most important is to preserve the cervical lordosis. And then, of course, it is meant that once you fuse that segment which is unstable, degeneration in that or above or below can be stopped by stopping the abnormal mobility. As you know, this Dr. Claver, good friend of mine, he died in 13th November 2000. He's the one who described anterior approach. He approached the cervical spine anteriorly from the right side. Next. However, orthopedic colleagues too, Robinson and Smith, they all use horseshoe-shaped graft, but they approach the spine from the left side. Neurosurgeon, even today, we all approach the spine anteriorly from the right side. Very important to know some of the landmark, because we have to take a small incision, which is skin crease. After about 1 month or so, you cannot see also where is the incision. It's horizontal. We don't take vertical incision. We always take horizontal incision, and if necessary, we can take 2 incisions. If the discs are at multiple, one at C2, 3, and one is at C5, 6, or C6, 7, we can take 2 incisions separately, no harm. But always better to take horizontal incision rather than take a vertical incision. The lower, you can see the lower red line is the cricoid cartilage, C6, 7 is below, C5, 6 is above that. Then the broad red line is the thyroid cartilage. C4, 5 is below, C3 follow either into the body of the thyroid or slightly above it. And then, of course, above that is the C2, 3 level. If you know this very well, then once you position the patient, slightly extended position neck and turn to one other side, then it becomes easy for you to make the incision on the right side. Next. You make the skin incision. You can also cut the platysma, and once you have cut, then you want to identify the medial border of the sternomastoid. Then you see the omohyoid. If you cut the omohyoid, you have to suture it back. This is nothing, no structures there. It's so easy, This is the carotid, and then on the medial side of the carotid are the hollow organs, the trachea and the esophagus. And if you go in the plane in between, that is your anterior cervical spine, so easy. You see the anterior longitudinal ligament, you cut it vertically with number 15 blade, as you see it here. And then once the disc is exposed, it is very, very important. You must confirm the level, where exactly you are. And then once you have done that, you cut the disc like a piece of cake, cut the annulus. Yeah. And once You can use small rongers, special cervical rongers to do that. The nucleus, if it's under pressure, it just starts coming out in young patients. As you grow old, if degenerates, the most important is to go to the neurocentral joint and open it. And while you must excise the upper portion of the corner of the lower vertebral body, upper corner of lower vertebral body. That is where the root is leaving the dura and entering the canal, and you must decompress the nerve root very well. Once you have done that, you can see, and this is a fuzzer cage which I originally introduced in the market and is being used at that time very commonly in most of the places. You can use it at one level, you can use it at two levels through the same incision, or through the same incision with micro. So you can do corpectomy also. This is a corpectomy. And these are the expanding cages that I developed. This is at one level corpectomy. I got a different cage for two level corpectomy. You can fix it very nicely, and then you can fix it, causing as much distraction as you want by looking at the C-arm picture in between. Yeah. All these instruments are manufactured for me by the Jasco surgical company in the South, Chennai, in India. That is it. It is firmly placed where distracted well. What is the rationale for fusion? You must, of course, maintain arthrodesis, maintain the disc height exactly as you want, prevent painful movements, and correct or prevent deformity if it is present. But almost all the time you must remember to maintain cervical lordosis. When I was in England, I used this skill bone. It came from Germany. I used a lot of that between 1970 and 1973. You can see the dowel graft of the kill bone, which is seen in the center. Next slide, please. And then when I came back to India and I started working at Sion Hospital, which is a public hospital, I required a lot of bone for my PLIF operations, and therefore, with the help of American technology, Gabriel, Mark, Cloward, etc., I developed a bone bank in Mumbai, first authentic bone bank in Asia, so that I can get a lot of bone from there to use either in the cervical spine or in the lumbar spine. So I had a choice. Now, ACDF is in autograft or allograft. Before I established my bone bank, I was using autograft from the anterior iliac crest. See, the whole issue here is that cervical spine surgery with lesser technology was such a simple operation that patient wanted to go home the same day in the evening. But he complained a lot of pain at the iliac crest, and that is what kept him in the hospital for a couple of days, in fact. So once I got this allo bone from my bone bank, so that part of pain in the iliac crest was given, and I started using allo bones, This, whether it's auto or allograft, both, it gives excellent results. I have got 20 years long-term follow-up with me. Very few complications, because as you say, people were unnecessarily afraid, but when you see the way I showed you, very easy to approach anterior cervical spine, and when people got expert, I tell them within 3 minutes, you must be there on the cervical spine. Next slide. See that left side allo bone from my bone bank? It is little harder on the right side, the auto bone. And these post-operative X-rays taken after 20 years, both of them cases illustrative, showing you very, very good fusion. In fact, you can find out even the anterior longitudinal ligament is reconstituted there. Yeah. Next slide. The beauty of not using any implants, and it was my pleasure at that time because I was doing a lot of research. I wanted to know what happened to the graft, how did it assimilate. So I had set up a research project doing CT scans on this patient at 6 months, 12 months, and finally last was 2 years there. And at the end of 2 years, you find, I was so amazed to see that the graft which you put, whatever maybe its texture, it ultimately took the shape of the vertebra, cancellous bone in the center and cortical bone at the periphery. It almost mimicked the vertebra in which that graft is lying. Experience with allover autograft, 738 cases, mean follow-up was 6.1 year, and I had produced 79% good or excellent results. And these are some of the, from the literature of the past, not present past, we showed their outcome varied from 67 to 99.5%, and I was at 79% in between some areas. Next slide. I assessed by using Neck Disability Index, DI, modification of ODI, 10-item scale, face validity, tested validity, and concurrent validity has been ensured through peer review and patient feedback sessions in large number of studies. NDI questionnaire, this is the NDI questionnaire. Next slide, please. Clinical results were assessed, preoperative and postoperative VAS and NDI. Next slide, please. And selective VAS score comparison between the VAS alone and the cage and plate show that using cage and plate, there is no significant difference if your cervical disc prolapse is at 1 or 2 levels. I have participated in debates on this use of plate all over the world, and then I realized, and I told the world also, that the world is divided. The West world always be using plate, even if it is a single level, whereas the East world is not so much convinced about the plate, and they are very happy, like me, to use only the graft. Time change. More technology came, more evolution came. I had to keep in touch with the technology. So I also give up this grafts all over auto bone. I also developed these further cases, which I showed you in the video. Next slide, please. And these are some of the cases. I use it at 3 level. You can see it. No plate. They are standalone cages working very well. Next slide, please. And then, of course, I change over these to further cages to octo cages, just like looking like a dowel graft inside. Next slide, please. Now, of course, again, as the time pass, modern times, fashion to use the PIC cage. I also started using the PIC cage. And these are some of the cases where I've done it without plate. And some of the cases I use plate because there are some intelligent patients who have preferred to have their plate rather than only the cage. I did object using them, not very strongly. If the patient wanted, I have given it to them. Yes, next slide, please. PIC cage, what is the study shows? There's no difference between PIC and titanium cages. And results show that it is absolutely Adam's criteria. Results show similar fusion rates. Possible complications. See this, in the past, we have talked a lot about this vulnerability to C5 root, getting sometimes weakness of the deltoid, which maybe I'll be temporarily, not permanent, but for a few months, It was unpleasant feeling and weakness for the patient, and you didn't know it, but it happened. But somehow or other, with advancing technology, finer instruments, we don't see it anymore. I don't know whether anybody has seen this C5, whether it is in myelopathy or only in the disc prolapse. And as Dr. Varnan said, you can get a disc prolapse with degenerated spiral. So these are the cases which are more vulnerable to this, but we don't see them now. Maybe that our technology has changed, we have finer instrument. Next slide, please. This is the effectiveness of plate that we use in some of the single level octocages and the plates. Next slide, please. Mean NDI difference between cage alone and cage with plate. Study shows that there is no significant difference by using the plate. And many times it is found that using the plate is just a gimmick rather than really helping the patient. Next slide, please. Then we have moved further and we have moved to motion preserving anterior cervical stabilization. Next slide, please. Dr. Oscar Alves will be talking in details to you about this motion preserving surgery. But why did it come? Why did you feel the need for dynamic disc? Because with fusion at 1 or 2 disc level, there was a significant amount of adjacent segment degeneration. Surgeons were concerned, patients were complaining, and that is how is the genesis why the discoplasty originated on the surgical arena. Next slide, please. When you use cervical discoplasty, what do you expect? You expect at least 90% success rate at the end of 1 year. There should be no subsistence of the implant. There should be no migration. ROM of the cervical spine should be maintained throughout all the years. There should be no spontaneous bridging by the bone anywhere, and there should be no revision. These are some of the ideal conditions expected when you use discoplasty. Next slide. What are the drawbacks? Restoration of stability and sagittal rebalancing. Stability and sagittal rebalancing can only be achieved with fusion. Let us see what Dr. Oscar Alves has to say about this particular sentence of mine. Next. I have used few. I'm not a very ardent follower of the discoplasty, but I use a few. First, I use DePuy. This is the DePuy pictures. Yeah. And this is the disc, which should be well countersunk. Yeah. Next. And this is the post-operative X-rays, neutral position, flexion, and extension. And then I started using ProDisc, which is also a very good construct. In conclusion, ladies and gentlemen, micro-anterior approach has remained the same. Technology has changed, methodology has changed, but the approach has remained the same. You must expose the medial border of the sternomastoid, very important, and then you are directly on the anterior cervical spine, and once you are there, do what you want to do. Use the microscope, endoscope, or anything else that is up to you to decide. What type of graft you want to use, it is up to surgeon and the patient. Fusion grafts have changed with changing time. Function preserving technology is very, very impressive, but somehow has not become popular. Therefore, micro approach that I showed to you, which I use even today, I have got a very sophisticated microscope now. It will remain a gold standard. Thank you very much for your patience. Thank you.
Thank you so much, Dr. Ramani, for that excellent presentation. This is what typically happens after any Dr. Ramani's presentation. You feel that you know the technique so well now. I just need a patient. I can just start off with the surgery tomorrow. I can do it successfully. This is what happens to anyone who attended his live cadaver workshop, live operative workshops, cadaver workshops. You are ready with the technique. Next day you can go back and start operating. I just would like to remind the participants, if you have any questions for any speaker, please note that in the comment section of your when you can view it, and we'll be discussing all the questions at the end of the session, and all the speakers will be there and they'll be answering the questions. Now, anterior approach has been covered. Let us see what Dr. Jayesh has to speak about and what new he's getting with his posterior approaches to cervical spine. Jayesh, all yours.
Yes, yes. Thank you, Dr. Amit. Sumit, am I visible? Hello, Sumit?
Okay,
So-
fine.
Sure. So first of all, I would like to thanks Dr. Ramani and NSSA for make provision of this wonderful opportunity. So after we have seen in completion of excellent talk by Dr. Ramani about anterior approach of cervical PIVD, today I would like to highlight some commonly encountered queries which as a practitioner we day-to-day encounter. Like see those patients of the PIVD, cervical PIVD, something is single and here lower 3-1 with the multiple with a variation in the sagittal cervical axis. So the common queries are when only posterior or when to choose a combined approach. Laminectomy with fusion or the laminoplasty. So how do we choose and which is better? Open versus MISs, tubular posterior decompression or the endoscopic decompression, and how, and which is better. So to solve that query, that also I also remain confused many of times about when especially you're dealing with the multiple cervical PIVD. I gone through this recent update, a recent research about this wonderful WFNS Spine Committee recommendation and the North American Spine Society's recommendation with the latest update. It includes all the randomized controlled trial and latest 10 years research evidence about the management options of the cervical PIVD posterior approach, which I'm going to use today. So when to choose indication of the posterior only or the combined approach? So if the most important factor is the number of level, so if you are dealing with the single or 2-level cervical PIVD, then you should look for the level of compression. If your compression is predominantly anterior, or if patient have a predominant axial neck pain as a chief complaint, then anterior approach is recommended, and it is as well described by Dr. Ramani. In patient with a posterolateral disc prolapse with a unilateral radiculopathy, which is very common, this is the only, and it's very rarely, if single or 2-level anterior disc, if it is associated with a predominant posterior compression like ligamentum flavum hypertrophy or ligamentum flavum calcification, in such case, posterior approach is indicated. You can do both open laminectomy and decompression from the posterior, and depend upon your surgical expertise and preference, you can go for a tubular microscopic or endoscopic discectomy or decompression. What to do when dealing with the multiple cervical PIVD, which usually present with the cervical spondylotic myelopathy, CSM? Again, the most important factor is number of level. So if it is more than 3 level, then you should look for the sagittal curvature with the help of K-line. Now, in the case with the lordotic or the neutral spine, straight spine, laminoplasty is the preferable option because in some range, it can reduce, it can preserve the neck motion. In case of kyphosis, and if your the degree of kyphosis is mild to moderate, or in dynamic X-ray, if your multiple cervical PIVD is having a flexible curve, it means on reduce on the extension, then the laminectomy posterior approach with the laminectomy and fusion is indicated. But in case of rigid kyphosis, which is a significant degree, always anterior release followed by posterior fixation means combined one. Especially when there is a history of laminectomy, in if your patient is present with the recurrent symptoms or adjacent segment degeneration, combined approach is indicated. So almost this guideline is very, very clear cut, except the gray zone. The advantage of laminectomy and fusion by the posterior approach is that you can, of course, logically can do an expansive decompression while providing the stabilization via fusion. Comparatively, when you do a laminoplasty, you can do a limited posterior decompression in cost of the, because you are preserving the posterior element structures.
Sumit sir, might internet connection lost from doctor. Sumit sir. Sumit sir, internet connection lost.
Let Ramani sir take over.
Am I visible?
Yes, sir, visible, sir.
Is there a connection loss? Yeah. Okay. Just see why there is connection loss. Sudesh.
Net,
Sir,
net connection problem at Jay, sir.
Yeah.
Sumit sir should take over.
Yeah. For some reason, we are not able to hear Jayesh. There's some problem with his connection. So I suggest that we move ahead, or should I try to call him once? No. No, I cannot hear Jayesh.
No.
No. So do you think we should come back to his lecture at the end?
Yeah, we can come to it
Yeah.
again later.
Yeah.
Am I visible?
Achha, Jayesh is back. Jayesh, are you on? Can you hear us?
Yes, yes, yes. So can I share?
Yeah.
Okay. So sorry for this disturbance of the network. So what I was saying, the laminectomy and fusion, of course, advantage is that it can do an expansive decompression while providing the stabilization via fusion. Comparatively, laminoplasty will provide you a limited posterior decompression in cost of the posterior element preservation. But on the long-term basis, all the studies shows that late chances of the instability after laminoplasty. Common complications are the C5 palsy, vertebral artery injury, dural tear, and infection after laminectomy and fusion. After laminoplasty, the very common complaint is inconsistent relief of the axial neck pain. Rather, it may worsen because of persistent microinstability. As Dr. Ramani explained, that a C5 injury is a common complication after a cervical approach, but is more common after the laminoplasty, and because of the stretching and direct injury of the nerve root against the foramen. And it is more common after laminoplasty than the laminectomy, because in laminectomy, we are also doing a foraminotomy along with the laminectomy. So usually never happen. But after laminoplasty, because of incomplete decompression exactly at the root level, it is a common complication. New neck pain is because of persistent microinstability. Relatively reduced range of motion can be seen after 3 to 4 years because of fusion at the site of hinge. And if in case of inappropriate chosen laminoplasty, you can have a new onset kyphoplasty. So what about the open versus MISs? So posterior endoscopic or the tubular microscopic foraminotomy or discectomy is indicated, especially for pure unilateral cervical radiculopathy without myelopathy, either due to a soft disc herniation, especially paracentral one or foraminal, or a hard disc because of osteophytes, or a multiple level foraminal stenosis without central canal stenosis. Now, what is the contraindication? So, of course, any case of myelopathy, especially a broad or centrally situated disc or OPLL, or case of instability, it is usually preferred not to be done, but significant instability. Now, let me explain with this case. A 33-year male presented with a neck pain with C6 radiculopathy. So patient is classical C6 radiculopathy, 6-month course without any deficit. And we can see here that there is a posterior disc prolapse here, exactly which leads to C6 radiculopathy with little bit straightening and little bit kyphosis at the sagittal curvature. So he was basically computer engineer. He came with all the knowledge gained from the medical Wikipedia, Googled. So he was asking about all the option. So what I have given, the conventional classical ACDF had a risk of adjacent segment disease 2.5% per year with the anterior neck scar of the disadvantage. I also give options of the motion preserving surgery. One is artificial disc replacement, similar clinical and radiological outcome and related with the ACDF, but the theoretical risk of heterogeneous ossification on 3-year follow-up. I also given a classical, very important motion preserving surgical option, either a microscopic tubular or a full percutaneous endoscopic decompression without fusion. So he opted for endoscopic discectomy. Now, let me highlight some crucial surgical aspect of the posterior endoscopic cervical discectomy and the foraminotomy. Basically, it is an interlaminar approach from the posterior area. Now, the identification of this V point is important because whatever we used, the method of endoscope or the tubular microscope, our retractor should be placed exactly at the center of the V. The V is made, arm is made by upper and lower lamina, and this apex is formed direction towards the facet joint. Now our objective is to decompress the cervical nerve root. So this V should be converted into U. So our objective is to convert this V to U. For that, you have to drill a minimal part of the upper and lower lamina, especially lateral part, and 10 to 20% of the facet joint. Just 10 to 20% of the medial facet joint drilling is required to decompress this. Now, compared to the cervical endoscopy, the lumbar endoscopy is more common. So I would like to highlight what is the difference while doing both. The more important is when you are doing a cervical endoscopy, 3 things to be kept in the mind. One is the course of the cervical nerve, which is deadly horizontal compared to the lumbar, in which it is vertical or oblique, about a traversing nerve. Second issue, as in the cervical nerve root, in the cervical vertebra is passed from the above the pedicle of the same number of the vertebra. It means in the foramen, you will going to find your nerve root at the lower half of the foramen compared to the upper half in the lumbar area. And third thing, while doing a discectomy, you should keep in the mind always that just 6 millimeter lateral to the border of the disc, you will find the vertebral artery. So it's very, very important while doing endoscopic discectomy that when you are operating from the outside, from the bone, is a laminofacet junction is the bony landmark for the medial edge of the vertebral artery. So you should never go aggressively lateral to this this line while doing a discectomy. So I take this patient into the prone position. Usually I take in the pin. Neck flexion would be helpful as it opens the cervical interlaminar space, so less ponytail is required. This is the Destandu's system, so localizer. So exactly C5, C6 and disc space is localized. Incisor is marked 1 centimeter from the midline on the site of surgery. Then obturator and this outer tube is exactly docked in the interlaminar area and should be confirmed wisely while doing a CM. When you introduce endoscope, just I'm like to highlight the surgery, important point. The most important is this, the V point. So we can see here that our tube should be docked exactly at the V point. And the upper one is a cranial, lower one is a caudal. Now our objective is to convert this V into U. For that, you need to drill just 2 to 3 millimeter, 4 millimeter, little bit drilling of the lamina. Ligament of flavum is being excised by the carries and punch. Comparatively, we need to require just 10 to 20%. We can see here that the medial part of the facet is being drilling, because our objective is to expose the horizontal cervical nerve root. Here is the cervical nerve root. Compared to the lumbar, the retraction of the cord is absolutely not recommended. Rather, just extruded part of the disc should be dissected and should be excised in order to free the nerve root. So it is very important while doing a bony decompression that it should be completely exposed. Nerve root should be completely exposed. For that, sometimes you need a drilling at just upper lamina, little bit drilling. Now this endoscopic curette is being utilized to remove the osteophytes for the hard disc or the calcified disc, which is very important. And finally, we should ensure that your nerve root should be well pulsatile and completely free. So post-operatively, this patient's neck pain, radiating pain resolved and patient discharged on day 2. But the important is we can see here that just 1 centimeter of interlaminar space is bony drill is required, and 10% of the facet joint need to be drilled. Now one can argue and criticize that about the posterior endoscopic decompression. Even in literature, that there can be insufficient decompression in the progression of kyphosis after a long term. So I would like to quote this study, a very important randomized control trial by the Sebastian et al. So what he has done, he compared the 100 patients of the ACDF, the 100 patients of the posterior endoscopic discectomy and foraminotomy. And what was the result? At the end, there was no instability or progress in kyphosis after PECF on long-term basis. The reoperation rate from both ACDF and PECF was almost similar, 4% and 6%. And clinically, there were no difference. The results were similar. What happens when you approach from the posteriorly, whether you do open or a microscopic cervical discectomy and foraminotomy, or you do endoscopic discectomy and foraminotomy, especially if your patient had a straight spine or little bit kyphotic? What happens after 5 years, whether it is increasing or decreasing, the kyphosis progress or not? So Jagannathan et al. Did this study. When you follow the 5 years, you see that after open posterior decompression, the kyphosis rate was 20%. And after minimal invasive decompression, there was no progressive kyphosis, even less than 10 degree. The definition of straightening of the cervical spine is when your cervical lordosis is less than 10 degree or more than 10 degree, there is no difference. So it means this posterior minimal invasive approach is very safe even in patient with a preoperative cervical lordosis less than 10 degree. What could be the reason? Mainly because of magnification by this endoscope, only 10% facet drilling is required compared to the 30% by the tubular or open discectomy in foraminotomy. So another case example, and this is a posterior lateral disc prolapse operated by this endoscopic discectomy. So coming to the end, in case of straight spine or the preserved lordosis, especially more than 3-level disc, laminoplasty is the option. If you are dealing with the kyphosis, if your kyphosis is a flexible and mild to moderate, only posterior laminectomy and fixation would be suffice. But if you are dealing with a fixed kyphosis, then anterior release followed by posterior fixation is recommended. Sometimes cases fall in the gray zone, like with the straight cervical spine. Till evidence is not certain which is a better surgeon's preference. Combined approach should be chosen for a significant ventral or a dorsal osteophytic compression that cannot be handled holistically with single anterior or the posterior surgery. What about MISS? A minimal invasive decompression by means of endoscopic or microscopic assays by preserving a spine biomechanics can avoid the requirement of the fixation, and clinical outcome is comparable by minimal invasive like endoscopy with very minimal risk of progression of kyphosis even in patient with a straight or even a mild kyphotic cervical spine. Thank you for your attention.
Thank you so much. Thank you so much, Dr. Jayesh, for that excellent presentation. You have taken us through the entire journey of posterior approaches from open to laminectomy, laminoplasty, tubular, fully endoscopic, destando, and everything. We had kept the question answer for the end, but you have, I think, answered most of our questions already in your conclusion. So with that now, we will request Dr. Oscar, who's, I can see him, to please speak on the cervical disc replacement, a topic that Dr. Ramani just touched upon and left it for Dr. Oscar to highlight and to tell us more about it. Dr. Oscar, please.
Okay. Is that okay?
Perfect.
Okay, so thank you for the invitation. It's really a great honor. This invitation by Professor Ramani, which is a big legend in spine surgery. And my topic today is cervical arthroplasty in degenerative disc disease. What's the current status, which is the first part of my lecture, and the expanding indications. I have no disclosures relevant for this presentation. And probably this is the first answer to the question of Professor Ramani, why it is not so popular. In this survey, where 383 AO Spine International members participated, they acknowledged the cost noise around the use of arthroplasty in the cervical spine. And when you look at the data coming up, it seems that arthroplasty is a highly cost-effective procedure in comparison with ACDF, even for two-level disease, as shown here. And if you pull out data from large national insurance database, like the real-world data, and on this paper, it seems that TDR is 12% cheaper. There are more savings over time, despite the initial cost of the device. And part of that is because there is a lower cumulative incidence of reoperation comparing TDR with ACDF. This very good, very interesting paper shows you with most of the studies were RCT studies, and you don't find any study showing that cervical arthroplasty is inferior to ACDF. And the more levels you do, you probably tend to have better results. And I'm going to run very quickly about the evidence that has been published with different devices. You see a good clinical outcome, a low rate of index level surgery, adjacent level reoperations, also a difference between TDR and ACDF with a 7-year follow-up. Another different authors with the same prosthesis showing basically the difference among the adjacent level reoperation rate. Another disc prosthesis, ProDisc C. Again, reoperation rate is lower for TDR compared with ACDF. With different devices, Brian and Canaflex, again, you see difference between the total reoperation rate, either index level or adjacent level. MOBI-C, level 1 data, prospective randomized study, good clinical improvement, fewer second surgeries in TDR, less adjacent segment degeneration, less adjacent level reoperation, as you see here. Again, MOBI-C, 7-year follow-up, 1 and 2 level. So very robust evidence showing that at least TDR is not inferior to ACDF. Secure C, again, the same figures. If you pull out the data from and you build up meta-analysis, again, it comes clear that total secondary surgery rate is lower with TDR, lower reoperation rate for adjacent level, and some of them showing even a superior neurological success. Again, another meta-analysis showing more or less the same. So in my practice and my understanding for single and 2-level disease, radiculopathy caused by disc herniation, either a soft disc or hard disc, you can have even some degree of ligament calcification. Even for myelopathy related to the disc level, cervical arthroplasty is standard of care for me, with a very firm and unprecedented evidence basis based in prospective randomized clinical trials with long-term follow-up, supporting the safety and efficacy of TDR. And you have to remember that TDR is probably the most scrutinized implant in the history of spine surgery. Very consistent results among different devices. And remember that all these big RCTs were done with earlier devices. I'm convinced that with the new viscoelastic compressible disc prostheses, like the ones we have been using over the last 7-8 years, probably the results will be even better. Why? Because they tend to mimic better the motion, the segmental motion of the cervical spine. They are compressible, and they have a graded resistance to angular motion. I show you a case. I have to warn you, the juniors in the audience, that I'm not advising TDR for cervical trauma, okay? This is a very particular case of a 37-year-old male, cervical trauma, diparesis, grade 3, 1-level disc herniation, X-ray excluded major instability, and on the MRI, you don't see any posterior band lesion. So why not to do, in this case, an arthroplasty? These were deflection extension lateral view X-rays, and we were able, due to this property of the graded resistance to angular motion of the prosthesis, to control for the hypermobility, the preoperative hypermobility. This patient had like 17 degrees, and the disc prosthesis give it back to 90 degrees, which is quite a good range of motion. So it preserved mobility and controlled for the hypermobility with a very good location of the center of rotation that become normal at 1 year, as you see here, and without any noise in adjacent level center of rotation location. So what are the facts about ACDF that Professor Ramani didn't tell us? It increases the adjacent segment range of motion. It changes the center of rotation. It increases the adjacent segment intradiscal pressure. Of course, you have motion loss and stiffness. And as you see here from many in vitro studies that you can pick up, this increase in motion is linked to an increase in intradiscal pressure. And the combination of that accelerates the degeneration of adjacent levels. And despite being the gold standard, ACDF represents a non-physiological operation in my mind, especially as Dr. Vernon showed, cervical spine is designed for motion. Very important concept I want to bring you, and probably you never heard about this before. It's the relation between fusion and aging. When you age, you have an increase in SVA. Of course, if you do a fusion, like here, there is an increase of intradiscal pressure at 667, but this ratio between the post-operative and preoperative intradiscal pressure increases with SVA. And this is something that you see with age. On the other hand, with age, and while increasing the SVA, there are some compensatory mechanisms, as you see here. Hyperextension of C0, C1, 2, and a compensatory flexion on the subaxial spine from C2 to C7. And by doing a fusion, you eliminate this kind of compensatory mechanism, which is very important, especially if you are doing fusions as we do in very young patients. They have a long life expectancy, and you basically, by fusing them, you are abolishing these important compensatory mechanisms. So there are plenty of biomechanical and in vitro studies that show that arthroplasty minimizes a lot of these negative kinematic effects. It's very difficult, especially when dealing at one level surgery, to have a study that shows a clear superiority of cervical arthroplasty over ACDF. You need thousands of patients to power your analysis in order to show really a meaningful clinical superiority. So in my mind, you have to look at 4 surrogate points of outcome, and these are range of motion and quality of motion, which is the center of rotation of the disc. One of my PhD students did a study with 31 patients, 46 disc prostheses implanted in very different environments. That's real life scenario, looking at range of motion and using the spine view for the study of the center of rotation of the disc. And as you see here, the ADR reproduces the range of motion of the different levels of the spine. And it mimics the relative percentage of movement along the cervical spine as in asymptomatic adults. And this stability of range of motion, it's maintained over time, as shown by other authors. You see that index level, there is an increase in motion, and minimally no changes in superior and inferior levels of the operated level. And there is also a global increase in the range of motion. And this is a scatter plot of the location of the central rotation, and it tends to locate a little bit superior and posterior at 6 months and normalizes at 1 year. So most of the clinical outcomes, they should be evaluated after 1 year, not before, because that's the time that it takes for the center of rotation to have a normal location. What about sagittal balance? Dr. Ramani was very skeptical about the capacity of ADR to reproduce or produce sagittal balance. I acknowledge it's very important. There is a relation between NDI and cervical lordosis, no doubt about that. So we look at some of our patients, consecutive patients, 35 patients, and these were the levels operated, and there was really minimal changes in the sagittal balance parameters with an increase in index level angle. And even the minimal increase in global lordosis was derived essentially from the increase of lordosis at the index level. And this has been shown by others, as Cédric Barré with another kind of implant. TDR restored local and global lordosis at 24 months. Some meta-analysis showing that arthroplasty can be better than ACDF on global alignment. And also at 1 year and 2 years post-operative, there is moderate to high evidence that the adjacent levels significantly become more lordotic after ADR than ACDF. So restores range of motion, limits adjacent level hypermobility, restores quality of motion, and has a beneficial effect on sagittal alignment. This is a mainstream case that that these were the first indications for arthroplasty, single level disc herniation, soft disc, minimal spondylosis. That's the long-term follow-up for this case. Here, I'm showing a very unconventional case, 35 years old female, severe dysphagia, neck and arm pain caused by disc herniation. This is idiopathic hyperostosis, and you see long-term follow-up, very good results. very good alignment, very good biomechanical result. She's free, pain-free, and amazing. The osteophytes that I drilled, they were completely solved, as you see here. And with a very good location of the center of rotation, both at the operated level and the non-operated levels. Of course, when ACDF fails, why not to think about ADR instead of creating a long, rigid segment? This is an example of one of our patients. So these were the accepted indications, as I said before. So we want to expand due to this good experience we have with TDR. We probably do around 100 implants a year for many years now. What about patients with index level that are kyphotic or collapsed discs, more than 50% loss of disc height and angular motion less than 2 to 3 degrees? And we did a retrospective study with our patients with segmental kyphosis, looking at pre-op and post-op neutral X-rays, measuring the usual endpoints and do the usual statistic analysis. We identified 23 patients related to 25 kyphotic levels. These were the distribution of the kyphotic levels operated with a more higher incidence at 5-6. There was a statistically significant increase in segmental lordosis in kyphotic levels, as you see this very, very nicely in this graph. No significant increase in global angle, and there was a trend towards the reduction of SVA in our patients. Here, a case that I'm showing you, a patient with 30 years old, neck and left arm pain, bilateral paresthesia to level disc disease, and a very pronounced segmental kyphosis, long-standing at 5-6, not related with pain, and see that with the arthroplasty, we were able to reverse kyphosis from minus 13.2 to lordosis of plus 5.3 degree. So in my mind, ADR can be done successfully in index kyphotic levels. It increases segmental lordosis as a side beneficial effect on SVA, and it's probably not a contraindication for ADR in selected cases. So what about collapsed disc? Collapsed discs represent an advanced form of disc disease and occur often in multi-level disc disease context. Here, I'm showing you a case of a 49-year-old female, high-ranking public administration official here in Portugal, multi-radicular pain, slightly myelopathic. And these are the patients we see more and more in the office nowadays. Quite young patients with a life expectancy of another 35, 40 years. And what you're going to do to those patients? Are you going to fuse them? You abolish those compensatory mechanisms I told you about before. So this is what we did. And that's the follow-up we have for her. She's asymptomatic and very happy and very active. Look at how the collapsed disc, we are able to increase the height of the disc. So we look at the very preliminary study with 7 collapsed discs, and there was a significant increase in collapsed disc height after ADR in our patients. And very interesting, more collapsed discs show the higher increase in disc height, as you see here. Also, there was an important increase in range of motion in the collapsed disc. Also, more collapsed disc showed a higher increase in the range of motion. We then, animated by this preliminary study, look at our patients with collapsed disc, and we studied 29 patients on 39 pathological levels. And this is a manuscript we are sending for publication. As you see, a very good increase in disc height and very good increase in the range of motion with a good change in segmental and global angulation. And this validates a study published in 2016 by Dr. Pat Worden with 8 patients showing that collapsed discs are amenable to TDR. So unless you have severe spondylosis with bridging osteophytes, facet joint arthrosis, osteoporosis, instability, global kyphosis, I consider still contraindications for this technology. This is how, I don't use Casper during my operation, retractor. This is how at the end of disc preparation, we assess, we use a 4mm burr to create a disc space, being careful not to damage the end plate. And this is how we assess at the end of the operation if we can insert a disc prosthesis or not, if we see that the segment is mobile. This is a paper that we just released on multi-level cervical arthroplasty, clinical and radiological outcomes on Journal of Spine Surgery. I invite you to read. And I have to tell you that since the beginning of this technology that we started to do preferentially over ACDF, we were always very interested in multi-level disc disease. If you operate one level, you don't lose much range of motion. But as I showed in one case before, if you do more than one level, 2 levels, 3 levels, this has a huge impact on cervical spine global functional status. And I'm sure the patients are not happy, young patients, in their quality of life with a 3 or 4 level fusion. So it can be a very important tool, either as a standalone or in combination with fusion in hybrid constructs. Basically, when you do multi-level fusion, you amplify what you're doing on a single level. You create a big stiffness and you hugely increase the range of motion of adjacent levels. Significant hypermobility, as you see here in one study that I selected from a specimen. So besides losing mobility, adjacent level hypermobility, adjacent level segment disease, you can have hardware failure, you can have pseudoarthrosis, you can have subsidence, and there is a direct correlation between the number of fusion levels and the incidence of these complications, as multiple publications have shown this. And pseudoarthrosis, young patient is a risk factor in multi-level. So does the fact of doing multi-level implants, TDR, bring the same benefit as doing a single level? A lot of papers are showing that, as this old paper from Huppert showing that 2-level TDR works as nicely as 1 level, and with level 2 evidence also that there were no major clinical differences between single level and multi-level MOVIC in this case. Multi-level have similar kinematic improvements to single level ACDR. And these 2 papers I selected show the greater improvement in the NDI, patient satisfaction, overall success rate. ACDF had a higher rate of subsequent surgery in figures that are important. Radiological segment disease, also more prevalent in ACDF than ADR, and the motion was retained for 4 years. Another paper that really shows the same conclusions. And another case here, 47, male, signs of myelopathy, 4 levels disease in the substenotic canal. And this is an option for this patient. And there are no concerns about primary stability of this 4-level arthroplasty. Of course, there are contraindications, spondylitis, ankylosing spondylitis, rheumatoid arthritis, severe spondylosis with bridging osteophytes, massive ossification of PLL, severe osteoporosis, osteopenia, absence of motion that you can assess on lateral dynamic X-rays, posterior facet joint arthrodesis. Of course, these are contraindications for this technology. So my conclusions are that clinical outcomes are similar or superior to fusion, associated with less adjacent segment disease, whether or not this is related with a lower reoperation rate. It seems to be the case with a more cost-effective treatment. Of course, I acknowledge that that can be a bias of the surgeon about the reoperation rate. And as our experience gains with the ADR, it would probably be the new gold standard rather than ACDF for single and 2-level disease. Surgical indications can be extendable in the cases that I show you by doing multi-level TDRs or hybrid constructs. There is still room for improvement. You need better device design because the older you get, the center of rotation of your discs will change. Also, if you are operating different levels of the spine, you have different location of the center of rotation. So you need almost custom-made devices. Thank you.
Thank you so much. Thank you so much, Dr. Oscar, for that excellent presentation where you have shared your experience and the latest literature about the ADR. It will be really nice to discuss all this at the end. I hope you please stick around with us so that we can take the questions at the end.
Sure.
And now I hand over the mic to probable mic to Dr. Srinivas Rohidas. We would like to learn from him the endoscopic approaches to the cervical disc herniation.
So good evening. This is about the endoscopic cervical approaches for discectomy and cord decompression. I am using distant use technique since 2002. This is the basic principle which I follow. Now this is a disc herniation, unilateral, compressing single root on one side, right side. And for this decompression, we compromise the whole disc. So this is pre-op and this is post-op. We have kept the normal disc intact. We have gone laterally and rest of the thing we have kept intact. So this is sort of a disc preserving surgery where we preserve the functioning motion segment. Now this is a case of a compressed cord, but there is a acute herniation. And this is the post-op where we have decompressed it. We use this Jones technique with the distant use endospine. The approach is transankle, supine position, localization with the cervical localizing pin and C-arm, and the incision is as usual. We go medial to the vertebral artery, transankle, diagonally down, maybe around 20 to 30% angulation to the root. If there is a central disc, then up to the center, and for the cord decompression till the opposite side. So during viewing the videos which I would like to present, you have to keep in mind that this angle which we are using for the root, which is something around 6 millimeters from the dural sac to the vertebral artery, then for the central disc or going on the opposite side. Rest 2/3 we try to keep it intact. This is the cadaver dissection, complete root, and this is the dural sac. This is the cervical localizing pin which we use. This gives you the direction to enter into the disc and to follow the disc. We reconfirm the level with the spinal needle again so that there is no wrong level. This is the outer tube with two mobile retractors retracting the visceral bundle and the vascular bundle. And this is the uncovertable joint. This is the inner tube, outer tube and inner tube. And then we start with the drill. This will give you the entry point and the direction to follow the disc. This is the exposure, uncovertable joint, transverse process. You have to use drill. And this is the exposed medial border of the vertebral artery. This is a soft disc. And this is foraminotomy for a soft disc, something around 6 to 8 millimeters. This is one more disc at C4-5 on the right side. The root is compressed here. This is C4-5. If you want to operate 2 levels through the same incision, you can target 2 levels. This is the uncovertable joint. Now it is a right-sided, so this is cranial, caudal, medial, and lateral. We start with the drill and we follow the disc. This is the uncovertable joint. This is how we follow the disc. The vertebral artery is somewhere here, and this is the extruded disc. dural sac, the root, and then we put a small gel foam over that. We don't distract the vertebral bodies. This is immediately after the surgery, after about 4 to 6 hours. No collar, no drain. He was not able to sleep because of the pain for last 1 month. So this is how we follow the disc. This is cranial caudal and this is the disc. Then when the medial border of the vertebral artery we have to expose, I use this ultrasonic dissector so that it is safe not to damage the vascular structure. So it removes the bone and we try to keep thin film of the bone over the medial vertebral border. If there is any vertebral oozing from the vertebral plexus, we use Surgicel. Now this is the foraminotomy. The suction diameter is 4 millimeter. Underneath the suction is the vertebral artery. We have kept a Surgicel over that. And this is the extruded part of the disc. So if we consider this as a 4 millimeter, this is something around 8 to 10 millimeters. And this is the exposed cord and the root here. This is the exposed cord and the root. This is a case of a huge disc. Compressing the cord, patient has presented with right-sided hemiparesis, young patient, and this is next day morning. No collar, no drain. We can use this technique for single level compressive myelopathy. This is a calcified OPL. OPL, you can say it is a calcified disc. Now orientation in this is cranial caudal, this is lateral and medial. So this is we are approaching from the right side. This is the uncovertable joint. Now this is the part of the cranial vertebra. This is caudal. This is the calcified part of the disc. This is the lateral. And again with the drill, we try to remove the part of the cranial and caudal vertebral bone so as to widen the foraminotomy. We start from lateral and then go medial to the opposite side. Now again, this is the lateral, medial, this is the disc. Then we remove the part of the osteophytes from the cranial and caudal. Every time we are protecting the vertebral artery with the suction. This is the osteophyte from the cranial vertebra. We are using 2 millimeter Kerrison punch. The cutting edge of the Kerrison punch is away from the vertebral artery. This is from the caudal vertebra. Now this is the exposure. This is the calcified part of the OPLL. We can use Kerrison punch to widen the foraminotomy. Then we go from lateral to medial. We can use drill. Endospine inner tube working channel helps the surgeon to support the drill. So it is safe. This is the caudal vertebra. Now this is the cranial one. Now. Then we can use Kerrison punch again to widen it. The difficult thing is the epidural oozing. You can see this oozing, it's troublesome. You cannot cauterize. You can use flow seal or you can use cottonoid. I use the cottonoid here. And then keep working on it, because it is difficult to use bipolar cautery at this stage. This is the extent of the decompression from one lateral end to the other lateral end and removal of the calcified part of the disc. You can appreciate this. You can move from one lateral end to the opposite lateral end. We have not distracted the bodies. This is at the end. Nowadays, we are using 3D endoscope. The depth appreciation is very good. This is single level cord compression with myelopathy, and you can see this is the decompressed cord.
Here the complete cord from right to left is decompressed.
I have used it for 2 levels also, something like an oblique corpectomy. This is the incision. Done on 77 cases, 20 cases of myeloradiculopathy, 57 cases of radiculopathy. This is the clinical, and I got good results in excellent result in 75. 2 poor results in cases of myelopathy where the decompression was inadequate and we have to convert it into open surgery. 1 dural puncture. This same technique can be used for posterior approach, unilateral disc herniation. This is something like a laminoforaminotomy. Soft disc without osteophyte, young patient. This is to know the direction, and this is the extruded disc in the axilla. This is the incision. We can tackle 2 levels through the same incision. This same technique can be used for posterior canal decompression in cases of myelopathy, where the compression is mostly from the posterior side, just like a cervical laminectomy, where we use this technique for hemilaminectomy, and the opposite lamina is undercut to decompress the cord or widen the canal. This is the ultrasonic bone dissector. I'm undercutting the opposite lamina at C4-5 level. This is the incision for C3 to C7 hemilaminectomy and decompression of the canal on the opposite side. So in posterior 42 cases, these are the levels. This is the clinical. In this, excellent result in 35 cases, good in 5, fair in 2. Where there is a cord damage because of the myelopathy, we don't get good results in those cases. This approach can be used for posteriorly for the intradural tumors. This is the incision, and this is the patient after 4 hours after surgery. So this approach with the endoscopic endospine is very good for disc surgeries, radiculopathies. The results are not good for myelopathies where the cord is damaged and where we are not able to judge adequacy of the decompression. Thank you.
Thank you so much, sir.
I think I finished in time.
Absolutely in time, sir. Absolutely in time. And it was a very, very nice presentation. The videos are seen very clearly. There was no problem with the videos at all at any point of time. And I thank you very much, Dr. Ridas, for that excellent presentation.
Thank you. Thank
Now
you.
we are going to take a few questions. I request Dr. Ramani to please address the questions which are relevant to the talk. There have been many, many questions. We have to actually chef out the question that will be appealing to the audience and is answering some particular question. Any repetition of the same topic of that has been covered in the presentation doesn't make much sense. I'm unmuting all the speakers. Sir, please take it.
Yeah, thank you very much, Sumit Pawar. We had a wonderful discussion on the topic that we advertised for this webinar. We have got a few questions. There is a question for Dr. Varnan Value. Doctor, what is the pathophysiology of facet arthropathy? Is it a part of spondylosis or a separate entity with separate progression course? It's a very good question.
Yes,
So, yes, please.
I think arthropathy starts with motion instability, basically. The moment the instability starts at the motion segment, then arthropathy is going to definitely start. And as the disc starts getting degenerated, that is the beginning of arthropathy, which would be in the facets, it would be in the uncovertebral joints also. And facet arthropathy can also affect separately as a separate entity if it is associated with conditions like osteoarthritis and rheumatoid arthritis. So basically, those are different entities, but once the disc starts degenerating, so that is going to be the start of arthropathy. And
Good evening.
can you hear me?
Yeah. Thank you very much. Wonderful, good explanation for that. I agree with you that this is how the things go. Now there is a question. Somebody has asked me a question. So why is the right side preferred over left side in the anterior approach? Do you do this surgery without a microscope also? Is a good question, yes. Why do on the right side, Because we are right-handed surgeons. Most of us are right-handed people. We like to stand on the right side and work on the right side. We do not go in the opposite way and do something which is not familiar. It's a very good question. You can do it from the left side also. It's not that not. Our mentor, Dr. Clower, who is no more now, he did it from the right side. He was a neurosurgeon. We do it, we follow the traditions, and we follow it from the right side. Now, what is the, without microscope also? I mean, you can do open surgery. So the concept of microscope is when you go to, for example, neurocentral joint, etc., you require better magnification. You must see it very clearly whether there are any osteophyte or not. And as I advocated, posterolateral corner of the upper body has to be excised if you want to decompress the nerve root. And for that, it's very important that you open out the neurocentral jet, see the nerve root. Microscope is very, very helpful. Once you are familiarized with any root, any approach, then you can do it with the microscope and do it without microscope also. What it means that if you don't use microscope, you have to take a longer incision. Does it matter? No, not really. It did not matter in the past. But here what happens, now the surgery is evolved. We are trying to get minimally excessive, trying to send the patient as quickly as possible out of the ward. Because of all these things, microsurgery evolved more and more. Now, what is the next question? Huh?
Yeah, this is for Dr.
Dr. Jay, how is your follow-up imaging protocol for missed post-operative approach for radiculopathy?
Yes, sir. Suppose the patient is operated by endoscopic discectomy. Usually, as I said, it requires just 10 to 20% facet joint drilling, and up to 30% till one-sided or bilateral, up to 30% facet drill. There is no possibility of postoperative instability. So chances of instability is very, very less. Still, for your answer, usually we prefer on day 2 of dynamic X-ray, flexion and extension at the time of discharge. Usually you discharge the patient on next day or day after surgery. So at the time of discharge, we usually discharge after dynamic X-ray. So that is what I want to say.
No MRI?
No.
No MRI? You don't do MRI?
No. We usually accept persistent radicular pain on such kind of things. Otherwise, it's part of our routine protocol.
You don't do MRI, yeah. If the patient is okay, patient is satisfied.
Yes, we don't.
More, then you don't do MRI, okay?
No.
Now, I personally want to ask one question to Dr. Rohidas and Dr. Jayesh also, both of them. In the posterior approach, as you know, as I showed you, lumbar disc is different, cervical disc is different. Cervical disc is quite small, and in that small disc, nucleus pulposus is still very small. When you remove the disc from behind, anytime, suppose the disc is very large, sequestrated. What is sequestrated cervical disc? That is, most of the disc has come out already. In such cases, posterior approach, would you prefer putting in a stabilizer cage? Yes, Dr. Rohidas, please.
Usually the patient has come with the stability which he has, and the prolapse disc has compromised that equilibrium. So the main purpose of my surgery is to tackle that extruded part of the disc and keep the motion segment at what he has.
Yeah, that is a compromise solution.
Yeah.
Huh? But you want better, because as Dr. Alvis also pointed out, and we all know it, age is advancing, and age is advancing, we have to live long, many years, So you have to think far ahead also.
But that aging is going to be there. We are not going to change that aging process.
Yeah. Dr. Sardara, please.
Yes, sir. 100% agree with Dr. Rohidas. Because the indication of posterior approach of endoscopy is only just decompression of extruded or degenerated part of the disc, and just objective is to decompress the foramen. So removal of only extruded part is indicated. As I shown in the literature, till date, I don't think so there is a chances of instability if you are drilling less than 30% of the facet joint. So no, I don't prefer to put anything. But yes, this idea is good. Later on, maybe in some cases we can do trial of putting of something from that approach.
Yeah, thank you very much, Dr. Sardara. I will now move on to Dr. Oscar. Oscar, now you are, I thank you very much. You answered one question very well, that as the age advances, degeneration also is there. From one level, it goes to multi-level. And therefore, you are obliged to relieve the pain by doing multi-level TDR. Okay. You have done multi-level TDR, patient is advanced, age, and all said and done, most of these patients do have osteoporosis also. Is there any subsidence of the disc inside anytime? Anyone, but not all? Anything? Have you observed? Subsidence, settlement of the disc.
Yes, of course. I mean, as any other implant that you use in cervical spine, you can have subsidence. Although I think subsidence is related with the technique as well. If during your disc preparation, your end plate preparation, you violate the end plate, of course you'll get subsidence. If using a cage that it's bigger in size than the disc space, it's another factor for subsidence. So, but I have to tell you, I have much less subsidence in my arthroplastic cases than in ACDF cases. Probably because I'm doing also on a younger population, you're right, with less osteoporosis.
Yeah. No, very good question. Another question that I would like to ask you that also, which I discussed with many people when I attended our Arthroplasty Society meeting in Seoul in Korea. All said and done, it is another story up to 5 years. The story may be slightly different after 5 years. And you may start seeing osteophyte formation at the level of the TDR also. What is your comment on that?
It's a good point. First, I don't think heterotopic calcification, it happens only on TDR. I have cases with ACDF that I removed the ligament, everything was properly decompressed, and years later I saw some ossification. Probably there was some residual motion. So it's not only on TDR that happens heterotopic calcification. I think most of the heterotopic calcification that you see, once again, is related with the technique as well. So there are several tips that you should use to diminish the incidence of HO. One of them is to remove the PLL systematically. If you leave the OPLL, it's a kind of scaffold for ossification to be done, okay? The other thing is you should try to use the biggest prosthesis as you can as a complete end plate coverage with the implant. If the implant is too short, you probably get some sort of heterotopic calcification. Also, abundant irrigation at the end of the procedure from the drilling to take remove all the bone dust. It's very important. Something that I do also is to bone wax all the cancellous bone surface that you have. So these are small tricks that can help you a lot to reduce heterotopic calcification. In this paper that we published in Journal of Spine Surgery, we have less than 10% of heterotopic calcification. Yeah. And it's probably, there is a tendency that you see less in multi-levels than in single level. I don't know why, don't have good explanation, but this is what our data shows.
Yeah, sure. Yeah, very good. This point also has bothered many people that, by doing this procedure, for some reason, may not be under your control also, you have got some bleeding there. And it has been observed and has been correlated that if we had bleeding during the operation, there is a chance of osteophyte formation later on. You touch on it. But see, so what do you think?
Yeah, I fully agree with you. That's why I never used killed TDRs with kills. That implies violation of the end plate and bleeding of the vertebral body. You know, that's something I never did. I never used a killed implant. You should avoid killed implants, in my opinion.
Yeah.
The new ones, you know, they don't have a kill, but they have a very good primary stability.
Yeah. There is one question that I will like to ask Dr. Varnan Value. When you showed your slide, you showed one person with very strong muscles at the back, but people have got very strong muscles in the front also, which are protecting the cervical spine. You didn't show any picture of any muscular man from the front. Why?
Yeah, because the neck muscles itself, anteriorly, they are not well seen as compared to posteriorly. So basically, for the cervical spine, I feel that the posterior paraspinal muscles are much more required to maintain the cervical spine posture and also for the maintenance of the cervical lordosis. Because it is not that weightlifters or bodybuilders do not get cervical spine disease. Okay, they do get cervical disc prolapse especially when they have too strong anterior muscles. So this is what is seen, and we have seen many weightlifters, wrestlers do get cervical acute disc prolapse. So it is basically the posterior paraspinal construct which should be a very strong aspect to keep your cervical spine stable.
Yeah. Thank you very much, Doctor. Now, I will ask one question to all the speakers of today, one by one. Question is the same, and that will be the last question of the day. Then we'll conclude this symposium. The question is, the age is advancing. As the age is advancing, so is the degeneration is advancing. And although people like us who are all the time telling people to do exercise regularly, so that you can maintain your muscles at least strong to maintain the very mobile cervical spine, people don't listen. That is the reality of life. People just don't do enough exercise to keep their muscles of the neck strong. So they become weak also. You got osteoporosis, you got multiple disc degeneration. What is your answer? What is your answer for these people? Should they have multiple level vision? Because this is a burning question. Although you see the X-rays, on the MRI, multiple level degeneration, but you cannot very accurately, and Oscar, listen carefully, very accurately localize the clinical symptoms related to all these degenerated levels. So would you, as some people have advocated over the world, would you do just as the most important two-level fusion, or discoplasty, TD, or whatever it is? Or do you do it at multiple levels? What is your answer?
When you have multiple...
Dr. Varnan Value first.
Okay.
Yes?
I think we have investigative tools.
It's not the question of thinking. What is your answer? Yes or no? Come on.
I wouldn't do multiple levels initially.
What would you do? What, two level, one level?
Yeah, I would address the level which is most involved first.
One level.
Yes.
One level, is that?
The level which is involved the most first.
Yeah, no, not first. In that patient, when you operate, would you only do one level or will you two levels?
That would be depending upon the clinical examination, and if I find that there is a second level involved and that warrants treatment, I would go ahead and do it.
No, I will again put that question to you again, because Oscar Ali showed one patient with 4 levels. And then he himself said that in the argument over there, no, I would do only 2 levels. I would not do all the 4 levels. Now, in this sort of situation, what is your answer?
See, basically, I do not do arthroplasty. I do.
No, it does not matter how do you do.
Okay.
What is your, whatever surgical treatment that you do, what is your answer? You do 2 level, 1 level, 3 level, or 4 levels. That is the
Yeah, my answer to that question is I will address the level which is causing the problems to the patient. I will not do something saying that it will cause later on.
Thank you. Dr. Rohidas.
I will try to preserve the functioning unit. That is the best, because if we want to prevent the further degeneration, if we want to decelerate that degeneration, mobile function of that facet joint or the joints is important. So I will do anything which is minimally invasive to preserve the function of the spine.
Yeah, but how many levels? 1 level, 2 level, 3 levels, or 4 levels?
If 2 levels are involved, 2 levels.
Huh?
If the 2 levels are involved, I will operate 2 levels. If the
No,
3
no,
levels,
4 levels are involved.
yeah, but without any fusion, only just because it is a question of the surgery is for compressed cord or the nerve.
Yeah. Okay. Or Jayesh.
As this is a degenerative process, and probably it's very extremely important to focus or localize that, as Dr. Oida said, that this is one level radicular problem or 2 level myelopathy problem. Majority of the patient, if obviously presented with a myelopathy, then we don't have an option. Obviously, we'll go for decompression fusion. But if we have as far as possible, we should do a minimal invasive spine surgery. And that is the reason why majority of open surgery has been converted to the MISs now, because whatever you do, this degeneration process is running on. So yes, the minimal invasive spine surgery at single level, a most probable level, will be the answer.
Right. Thank you. Thank you, Jayesh. Now I'll ask that question first to our young surgeon, Sumit Pawar. What do you think? What do you think about this degenerated spine?
Sir, I would, Indian scenario, I would prefer to deal with all the levels at the same time. Patient has come for surgery for relief of symptoms. I'm not going to wait for the other 2 levels to develop symptom and then I'll treat them later on and everything. If I have a patient with 4 level degenerated spine, 2 to 3 of them are causing radiculopathy right now, I will treat all of them at the same time.
Wonderful. You have already said, you have once showed that case of 4 level TDR, but you said that, some people said that, no, I'll be happy with doing 2 is also like that. I will ask that question again to you. What is your final answer? Because so far, except for the young neurosurgeon who aggressively said, no, I will do all the questions, I was not too happy with the answers given by the other speakers. So finally, I will come to you. What is your answer in extensive degenerative spine in the elderly?
So, first of all, I have to tell you that this 4 level is an exceptional case. So my principle is to treat what the level I think is causing the clinical problem. I'm either radiculopathy or myelopathy. Then there is another issue that needs to be addressed. There is this very good paper from Hildebrand showing that the reoperations at the adjacent levels, most of the discs were already degenerated at the time of the first surgery. So for me, this is a good argument to include the degenerative discs, even though they are not symptomatic in my surgery. So it's a way also to avoid the complications of a reoperation, which are bigger than the first operation. So that's generally my way of thinking.
Yeah, thank you very much. Just one brief question lastly before we depart from here. We have, when we started adjacent level degeneration, and we are all the time following the 82.9% per year and all these things with them. Surgery has changed, concept have changed, microsurgery has come into that, minimal invasive has come into that. What is the scenario today for adjacent segment level degeneration? Can you answer that question? Yeah.
Yeah, you know, you have different levels of analysis.
Yeah.
You have radiological degeneration, you have clinical degeneration, and you have reoperation. And you have all sorts of bias when analyzing that.
I don't respect radiological ASD. I respect clinical ASD.
Yeah, exactly. So you have to be very careful. And the one that it's important is clinically significant ASD. And if you have a previous fusion, I think a good option is to do a arthroplasty. You decrease the rigidity of the spine by you protect more the spine. So I would tend to offer for adjacent segment disease arthroplasty.
But how often, how frequent it is ASD today?
Oh, I see. I mean, I see it more in fusion than in my arthroplastic cases. And the percentage, it's probably around 5 to 10%.
Per year?
Per year, yeah.
For your series?
No, I'm sorry, in total. That's what I'm seeing, not per year. Per year is less than that.
But how many years follow-up you see? 5 to 7%.
It's something that comes the more you follow the patients.
You can increase it by increasing the number of years also.
Yes. So the more it's clinical ASD is follow-up dependent.
Yeah. Thank you very much, Oscar. We had a very lively discussion today.
Ramani sir?
Yes.
Sir, before we go closing, I would like to know your comment on that question, because it's very important to know your perspective on 4-level or multiple level.
Yeah. Thank you very much. Thank you. See, there are two issues as far as I'm concerned. Number one question is operative technique. Any surgeon must be like a Picasso painter, like that, You cannot take because you got a brush in the hand, that means you don't become a painter. Similarly, if you got an instrument in the hand, you don't become a surgeon because the university has given you the degree of surgeon. It is a question of passion. You must have passion for any science. You must be mad after it. It is only then you become perfect. If you don't have passion, you don't become perfect. And if you are not perfect, your technique is not perfect. And if your technique is perfect, then your complication rate, including ASD, is much less. That is first. Secondly, I have observed, it's my observation, that ASD goes on increasing or goes on decreasing as the level goes up and up. C6-7, there is more ASD. C5-6, little less ASD than C6-7. C4-5, there is less ASD. This is how it goes, pattern it goes. Depends on what level you have done the fusion or TDR or whatever is the procedure you have. That is my observation. Thank you very much. Once again, I thank you all the speakers. Dr. Rohidas is raising a very brief comment. Dr. Rohidas.
I'm not going to comment. I'm just want to ask you. You have seen spine surgery for 4 or 5 decades. What is going to be the future?
What is going to be the future of cervical disc or spine surgery? Spine surgery. See, the future is very, very bright for spinal surgery. I have no doubt about it. What I have got worry, what I have doubt about the future surgeons is the misdeeds. I have no doubt today, and it is statistically proved, that there is always a liaison between the surgeon and the instrument manufacturing company. Very bad for the progress of the science. Many times surgery implants are overused. It is a research people has been found. It is established. Many times surgery done which is unwanted. You could have done a much simpler operation. So all these misdeeds, if we can avoid, and you have to be passionate, is very difficult because today everything is commerce and so is surgery. I'm sorry, I feel very sorry to utter this comment, but surgery has become commerce today. And that is my greatest regret at a time when I am virtually I'm 82, so virtually at the retire end, but because of my good physique and good mental faculty, I still continue practicing. But that will be my greatest regret today, is the surgeons. Thank you very much, all of you. I also thank viewers for very patiently listening to this. And I also thank once again Intas, pharmaceutical company, Ultima division, manufacturers, Reginex, CDT, Livera, etc. Thank you very much. Thank you. Goodbye.
Thank you, sir. Thank you, Sumit, for moderation. Wonderful moderation.
Thank you so much. Please stop streaming.
Prashant bhai.
Yes, sir. I'm doing
Please
that.
stop streaming. Don't close the meeting.